back to We Do the Heavy Lifting. I'm your host, Dr. Jenny Yentis, and today we do sports medicine. A lot of us in the general population think of sports medicine. We think maybe that refers just to athletes. Maybe that's just a shoulder injury or a torn ACL. What does that really mean to our community? What does that mean from a medical standpoint? And I'm really excited because our guest today is Dr. Laura Marsh, and she is from Texas A&M School of Medicine in the Department of Primary Care and Rural Medicine. And you also lead the Sports Medicine Fellowship for the School of Medicine. And you're also the team physician for Texas A&M Athletics.
Correct.
You wear a lot of hats.
I do.
You
There's
do.
a few.
So growing up, or how did you get on this path towards sports medicine? Let's start there, because you are a physician, you're an MD, and what kind of led you to med school? And then at what point in med school were you like, I like that, I'm going to go that direction?
I grew up playing sports in high school, but I don't know that I even knew that sports medicine existed as a specialty. And so came into college at A&M and was interested in pursuing a career in medicine, and worked with a lot of family medicine physicians during that time period, shadowing on a weekly basis. And I really enjoyed the primary care, relationship building, taking care of the whole person aspect of that. But I also really loved orthopedic surgery when I got farther into medical school rotations. And then once I was introduced to sports medicine as an option, it just seemed like a really great fit, because it was a combination of a motivated patient population that wants to feel better, wants to do better with that same kind of non-operative orthopedic subject field. But there are a lot of the patients that I see in my community practice that I've seen since I started working there 9 or 10 years ago. And so I've still had the beauty of having kind of a relationship built with a lot of those patients over time, and just trying to help people feel better and live their lives better, whether it is an athlete or whether it's somebody that just wants to continue to live an active lifestyle. So
from a medical point of view, why would you refer somebody to a sports medicine professional versus maybe an orthopedic surgeon or another specialty?
I think that's really, the name is intimidating to a lot of people, because they think, well, I'm not an athlete. Like, I don't need to go to a sports medicine clinic or see a sports medicine physician. But I would say the vast majority of my patients that I see on a weekly basis are not your stereotypical athlete. They are people that are moms and dads and grandparents and professors and working people that are just trying to be better. And whether it's an acute injury or whether it is a chronic overuse or degenerative type injury, they all have one common goal, and that's to get back to their activity. Some of them are athletes, and certainly the patients that I care for within athletics are an elite level athlete, but all of them really, when you look at it from a global perspective, have the same desires and the same goals. And so we see everything from fractures and rolled ankles to rotator cuff tears, arthritic knees, back issues. And I try to also implement some lifestyle changes in lifestyle modifications from a dietary perspective. How do we change our diet? How does our sleep influence how we feel? What can we do to lower inflammation and thus feel better?
So it's kind of a holistic approach to the care of the person, is kind of understanding, even though I'm going to see you as a sports medicine physician, at least your approach to care is to really understand the entire individual. How is that different than from my family doctor? Or do you serve as a family doctor or like primary care for some individuals?
I really don't serve as primary care physician anymore for anybody other than athletics, but I take some of the principles of that and work them into my day-to-day practice. Where we differ is that the majority of patients that we see and the majority of things we take care of are musculoskeletal issues. And so
for our general population.
What does
musculoskeletal mean?
So anything
guess,
with bones and joints, tendons, ligaments, anything to do with your body staying upright, movement, and mobility.
Okay.
And so we just see almost exclusively that on an everyday basis. So we're well versed in treatment modalities and options, whether that is physical therapy or home exercises that are prescribed. medications, some supplements, but also targeted injections of different varieties. And that can be everything from cortisone injections to things like platelet-rich plasma and conditioned plasma that we also use in the elite athlete level.
Interesting. So plasma is a component of the blood, right? And so you're taking what you platelet enriched. I think of terrible analogy, but I think of like enriched cereal where they fortify it with something. So it's like fortified with.
Well, so the process involves drawing the patient's blood just like you would if you went to a lab. And then that blood product is then spun in a centrifuge, and we're essentially separating the majority of the red blood cells out from the rest of the plasma.
Okay.
And so what we come back with is a concentrated or conditioned plasma product that's essentially devoid of the red blood cells, but is full of the chemotactic factors, growth factors, good things that promote healing. And so then that product can then be injected back into a joint, into an injured tendon, or into a muscle injury, and you're using your body's own healing properties to try to promote healing. It's not perfect, but it's certainly an option for a lot of people.
That's interesting. I never thought about using your own blood as almost, when people say injections, of course you mentioned it, cortisone, which cortisone is a steroid,
It's a
correct?
steroid, yes.
Yeah, so that decreases the inflammation.
Correct.
Now I've got a question for you that maybe some of our other listeners have. I've always heard that even though the cortisone may make the pain go away, it hasn't helped the injury. Is that correct? Or
For the most part, yes. So it's not going to necessarily promote healing. It does reduce inflammation, and that will help you in the short term. And depending on what the injury is, your body may go on and deal with whatever the issue is on its own, and we've just helped it along from a swelling and inflammation standpoint. But for patients with, let's say, a chronic rotator cuff injury or an arthritic knee, all we're doing is making them feel better for a period of time, but we're not changing anything within the joint per se.
And so at some point in time, they will have to have if they can't do it with a non-invasive, and when you say non-invasive, non-surgical,
Right.
eventually then that tends to lead to a surgical intervention.
Right. And that's the way our practice generally works, is that they start with us. We try whatever non-surgical modalities we can try that the patient wants to try. And then if at some point we're just not achieving the results that we need, or something changes in lifestyle and things just are not working, then we send them on to the orthopedic surgeons who then can operate and do something more definitive.
Is there any similarity? So you said that you're essentially the primary care physician for the athletes here at Texas A&M University. Is there overlaps in care that you provide to the community, to the athletes, or what's different about? Obviously it's a more active population probably that you're dealing with. What are those compare and contrasts between the two populations? Are there techniques that you use in one that you can apply in another? Or?
I would say for the most part, the techniques are heavily overlapped. And so the same type of physical therapy, nutritional therapy, injection options, medication options are very much the same in those two, though in a younger population, we don't tend to use the cortisone quite as frequently. But as it stands now, the general population has access to a lot of those things that they maybe didn't used to have, things like ACP or PRP injections. But the principles are much the same. We just may be a little bit more aggressive in our timeline with an athlete that's, say, in season, as far as when we would use a platelet-rich plasma injection, or when we would go on and send to physical therapy, or when we would request an MRI. Those things may come faster in a timeline in that patient population as opposed to the community. But if you really look at it from, the upper level view, it's very much the same.
Well, I appreciate you saying that. I think that the general population sometimes has this view of athletics, whether it's professional or collegiate, that they're getting some sort of access to some care that not everyone would have access to. So
And the goal is to provide the highest level of care that we can for the athletes. But then personally in practice, my goal is to provide much the same care for our everyday patients and try to make things accessible that are coming out, that are developing, that are new treatments and new therapies, and treat everyone much the same, though with each having a different goal.
Yeah, absolutely. So within the community, you had mentioned rotator cuff injuries or arthritic knee. I'm going to make a very wide generalization here that Americans are not the most active populations. I think that's probably fair. I think the world around is starting to become less and less active. Mm-hmm. And you had mentioned lifestyle changes that we can make. So for the average listener, is there something that they could start thinking about doing if they maybe have a little ache or a pain? Do I go to the doctor the very first day that I, feel that? Or how do I differentiate what I can change lifestyle-wise versus then when it's getting to a point when I need to see a professional?
Need to do something else. There's so much of the lifestyle changes that impact us across the board. And so it's the musculoskeletal orthopedic things from a pain standpoint, but it's also our gut health and cardiovascular risk and brain health and all different things that are directly influenced by that. We all need to be moving. Right? Movement keeps things going. It maintains good muscle mass, and it's good for our bone health. And so generally speaking, most people should be getting at least 30 minutes of moderate activity a day, 5 days a week. And so it's 150 minutes. And that is, taking a walk, but it's brisk enough that you could have a conversation, but maybe you couldn't sing a song.
Okay.
And so, maintaining that level of mobility, some resistance training, strength training. If you're not doing anything, maybe you should talk to your doctor before you take off on a totally new program, but in general, we should all be moving. We ideally are getting at least 7 hours of sleep every night, high quality sleep. Dietary, lowering inflammation with reducing sugar, reducing fast food, processed foods, more whole foods, more plant driven, high quality lean protein sources. All of those things from the inside out will help us. So much of what we see in practice is inflammation driven if it's not an acute injury. And we can mitigate some of those symptoms by making some of those lifestyle changes and trying to minimize how many pills we're taking, how much Advil and Aleve and things like that.
So when you're saying inflammation driven, you're talking about the immune system essentially, like, you take the labs, it's just the white blood cells. Is that kind of like it's just the body reacting?
It's the body reacting, and you may or may not see it reflected in labs. Sometimes you will see it in a couple of different markers. But generally, it's more of a systemic imbalance within the body where we have increased inflammatory mediators. And some of those things like exercise and sleep and our diet that actually can act as anti-inflammatory, you end up with that imbalance there. The standard American diet, the standard American lifestyle generally is very pro-inflammatory, and that's created a lot of the problems that we see.
Yeah, we previously had a guest, Brian Schneider, who does performance nutrition, and he was speaking similar to you about shopping, or I brought it up, shopping the outside of the grocery store, trying not to shop on the inside.
Right.
And here we're hearing it again. So it's a good reminder to all of us that thinking through those changes. And I think a lot of times some of these lifestyle factors that you're talking about aren't related to maybe I'm hungry or something. It's more comfort. It's like, I had a really hard day at work. Why am I going to go take a walk for 30 minutes at a brisk pace? It's tough to change.
It is, and it has to be intentional.
Yeah.
And what most people end up coming back and telling me when they do really make some of those changes is that they really do feel better.
Yeah.
It's getting there. It's the doing of it, and whether it's finding an accountability partner or a health coach or somebody to work with, or figuring out what motivates you. Do you need to log it in a tracking app, or do you need to wear a fitness tracker? There's options there that help us as humans find that accountability, because the reality is we're busy and you just want to go home and put your feet up and be done for the day. But if we will really take those steps and make those changes, then on the flip side, we end up really feeling a whole lot better.
Yeah, it's the intention that it's difficult. And I think a lot of times people, they always want to start on a Monday, which I've heard trying to create a habit starting on a Monday is usually the worst day to try to start a habit.
Yeah, probably so.
So maybe try a different day. But I think of things of, if you don't do it perfect every day, then you really get hard. You're hard on yourself.
Right. You've got to give yourself grace.
Yeah.
Right. We're not going to be perfect. Set goals. If you think it's reasonable for you to get out and walk 3 days a week.
Yeah.
Start there. It doesn't have to be every single day. And if you miss the checkbox, it's not the end of the world.
Exactly. You have to be kind to yourself.
Yes.
I remember once I had a counselor that was like, just sit for 10 seconds and let your mind be blank. And it took me forever to get to 10 seconds. And I would get so mad at myself because I'd be like, oh, I'm not at 10 seconds yet. So the intention it's difficult. It's sometimes hard just to get going. And,
it is.
And get that first one
Take those
done.
first steps, and it takes time to build habits.
Exactly.
So you've got to be consistent as you build those habits.
Yeah, absolutely. So in general, sports medicine is a pretty wide net. It looks like it's casted. But if you could know the answer to any question regarding sports medicine, what would that be?
Goodness, there's so many things, and there's so many things that are coming and developing, even in the realm of things like regenerative medicine. But I think one of the things that sports medicine on the non-orthopedic, non-surgical side that we have not really mastered is concussions. And we've certainly gotten better. We know more than we used to. We have gotten better at diagnosis as well as some treatments, particularly as they pertain to like vertigo and some of the dizziness that people can have. But we're still not really where we all hope to be, which is better understanding how do we really prevent them, right? There's different football helmets, and there's different mouth guards, and there's different things that are in development that might help prevent them. But then how do we diagnose them accurately? So much of it is very subjective based on symptom reporting. And there's hope that at some point there'll be either a blood test or an imaging test or something that we can use to help really hone in on the ones that are maybe a little bit difficult to diagnose. And then also on the recovery side, how do we really help people recover and help them get back to normal and not have any residual effects from that? Like I said, we've gotten better, but it's still not really ultimately where we want it to be. And
they seem to compound. It's like, I don't know how to. It seems like once someone has one, the next one, it's not like I don't know, like you break an arm and it heals, right? And then the next one, it maybe breaks in a different spot, or you break a different. But it seems to compound the previous one, and then you end up with what is the condition?
Well, either CTE in the long run, or even like a prolonged post-concussion type syndrome. I'd say the majority of people recover and do okay, but what we don't really know is what is that compounded effect. There's so much that we can't see. You don't see it on an MRI. You don't see it on a CAT scan. And so, studies have come out mainly out of the NFL that indicate that those repetitive blows do cause long-term damage, but we don't really know what that necessarily looks like in the general population. And so being able to better identify, better treat, better diagnose will ultimately lead to better long-term outcomes. But work is still being done every year. When we go to conferences, that's one of the topics. And there's always something kind of new that's coming out, but it's still not perfected.
Yeah. It's definitely one of those areas where athletics has led the way, and the general population will benefit from the work that we're doing in athletics, that we discover something, or we can understand how it's happening at that high performance level, and then you can extract that for the everyday average person, it's great.
Yeah, absolutely. There's so much in sports medicine that's driven somewhere along the line by athletics, but the reality is so much of it applies to everybody.
Yeah. I mean, I hope that our listeners understand that, and I really appreciate you being here. So thank you so much, Dr. Marsh, for being with us today.
Thank you for having me.
And we always ask our listeners if there's a little tidbit that they'd like to leave for our listeners. Is there advice or something on the topic that you'd like to just leave them with?
I guess what I would say is, don't be intimidated by the idea of somebody being a sports medicine physician or a sports medicine practice. There are a lot of things that we can help with. That's both the obvious and then the less obvious, with things like lifestyle changes and encouraging activity and exercise prescriptions. So we can help with a lot of different things. We're kind of a bridge between the orthopedic surgeon and the primary care surgeon, and we try to fill a lot of those gaps.
Well, thank you so much again for being here, Dr. Marsh. We really appreciate it. And thank you to our listeners for joining us for yet another episode. As always, if you have a comment or a topic that you would like to see us explore, please email us at huffines@tanu.edu. And as always, stay healthy.
Thank you.
Thanks again.